Good morning and welcome to Breakfast with the Chiefs. I am Matthew Hart, the publisher and CEO of Longwoods Publishing. Not the nicest morning, so fantastic applause to all of you for making it out today. I know that I don't like coming out in these mornings, so good for you. As always with Breakfast with the Chiefs, it is not possible without the support of our sponsors. So supporting today is the Canadian Foundation for Healthcare Improvement, Health Tech Consultants, Iron Mountain, and Navarre Health. And also a big thank you to Lee Cushing and St. Michael's Hospital for allowing us to use the auditorium this morning. So, without any further delay, I would like to formally introduce the Chair of Canada Health InfoWay's Board of Directors, Dr. Peter Vaughan. Thank you.
Thank you very, very much. It's great to be here on this wet kind of day, but it's going to clear up because they have great algorithms at the Weather Network, and they tell me that it's going to clear up by about noon. So we'll see. That's sort of relevant to our conversation today. Great to be here again. I've been in healthcare 46 years. That's a long time. And I've seen a lot of change. And I see how challenging change is. You've seen how challenging change can be. But yet I can also tell you that I've seen a lot of things stay the same. And I think that's one of the challenges. You know, 46 years ago, when I say I've been in healthcare for 46 years, I haven't been a physician for 46 years, although that's one of my backgrounds. I started out in high school as an orderly in a psychiatric hospital in Guelph, Ontario. And I was part-time, of course, but in that role, I was looking after patients who had had psychosurgery, frontal lobotomies. And these are people who couldn't go home. They were quite normal to talk to, fascinating individuals, fascinating stories that they had created in their own minds, but they couldn't function. And this had a profound impact on me, because it really made me think about the good people who were trying to help those people. At the same time, these people's lives were permanently impaired. So that, to me, was our conversation around change, and both the risks and the opportunities around change. And what I'm going to talk to you today is really around changing our thinking about the future. This is a talk about an ecosystem, about a 21st century ecosystem. It's really important for us to think about what an ecosystem is. There is some wonderful research now amongst the natural sciences around the interaction between trees and funguses and how they communicate in this network that is going on way beyond our eyes, that helps contribute to the oxygen in the air and the environment that we live in. And also this mysterious sort of web of viruses that circulates in the air, way beyond even our comprehension a few years ago, and into the trillions that's going on around the planet all the time. So all of these things are part of a living organism, a living ecosystem. And when we talk about that in the context of healthcare, we need to think about the risks and the opportunities. Because in the ecosystem, there is a delicate balance. And that delicate balance includes the predators and the prey, as we can see. And the predators and the prey don't overwhelm each other, or the ecosystem is disturbed. Where it becomes problematic is when people get into the equation, because we seem to be the ones who are most unfamiliar with the need for balance in the ecosystem. And I think this is relevant in our conversation going forward around technology, because sometimes things appear on your doorstep that you might find threatening. And it's really our approach and our insertion into the ecosystem that has caused that threat. I used to talk a lot about black holes. I'm a real fan of astrophysics. It's a hobby of mine, and I love the phenomena of the black hole, not because it's gobbling up things across the universe, although that's obviously a great storyline. What I'm really interested in it is because it challenges our thinking of the universe. It challenges our understanding of Newtonian mechanical understanding of the universe and quantum mechanics and how these interact, or they disrupt, more essentially, our understanding of the universe. In a similar way, we are experiencing a disruption in the healthcare environment. And it's not a black hole, but it's a black screen of possibility that has risks and opportunities associated with that, maybe far beyond our understanding of the technology in terms of the social implications of these events. The 9/11 Commission, many people don't refer to that. 9/11 Commission's ultimate conclusion was a failure of imagination. A failure of imagination on the part of the intelligence communities to imagine a scenario of that sort. We have a great risk of having a failure of imagination to understand the implications of the convergence of biology and technology and the opportunities that they afford, but also the risk, and we're going to talk about some of that. One of the things that we also need to think about in that potential failure is our understanding of health human resources, of the kinds of people who are going to be needed to do the work. Because remember, a lot of things have changed, but a lot of things haven't changed. And those societal structures haven't changed. I always like to remind us that we do not have polio hospitals or polio doctors or polio nurses anymore. Biotechnology changed that, and it disrupted a whole landscape. And we'll talk more about that. There are great opportunities and there are great risks, and we want to highlight some of those to you. Healthcare, as you know, is very fragmented. Most people don't think about it on a daily basis, but we still live in pretty much a 19th century structure of cottage industries. Most healthcare is delivered by primary care providers in their private offices. Yes, we have these wonderful institutions, and yes, we have structural regions and governments and all of these other factors, but it's still very much a cottage industry. And attempts to be able to weave that together have been somewhat problematic and with a great deal of difficulty. But I think there is a great opportunity to weave that together with digital healthcare. You don't really have to be somewhere else. You don't have to change your own particular structure, but you can weave it together. Now, one of the challenges of the fragmented healthcare system that you all know is the data silos. There's great information in many places. Doctors' offices, clinics, hospitals, governments, insurance companies, pharmacies, research organizations. The list goes on and on and on. My friend, and some people may know, Anne Snowden, a researcher at University of Windsor Odette School of Business, told me last week on a call that it took her 3 years to come to a data sharing agreement with 2 hospitals in downtown Toronto. 3 years, okay? And that wasn't a complicated data sharing request, just to share data with 2 hospitals. So the silos, I think they're titanium reinforced silos. Everybody wants to control their own data. Everybody wants to have access to their own data. Lots of talk about sharing data. It's really hard to do, is what I'm told. Now, there are many ways to overcome this. This is not a technological conversation. There is not an issue with interconnecting the technology. Health information exchanges have been doing this for a long time in other jurisdictions. For us, I think it's about how we think. That disruption is occurring today, and that disruption is beginning right now, with all kinds of data being used and gathered and being used all around the world and all across this country in various formats outside of some of those other silos. That becomes both the challenge and the opportunity. Are you familiar with Amelia? People know about Amelia. Amelia is an artificial intelligence agent who's customized on the front end. And that's important because Amelia can read emotion and adjust her responses to your emotions. That's today. I'm not talking about the future. I'm talking about right now. And those technologies are being modified and used in jurisdictions to help with the access to mental health, for example, in a way that's unbiased, for example. Humans tend to have some bias in there. You can customize the cultural interface. You can do a lot of things to help improve the access. What are the challenges associated with that? Well, you can imagine. We'll come to that in a minute. I like to talk about the Netflix of healthcare because it's already here. There are many examples. Some of you may have heard of Babylon. Babylon's a UK-based company. They have over 2 million patients, clients, customers in Rwanda, all over the world. And it's $9 a month, right? It's the Netflix of healthcare. Gives you complete access to your healthcare provider, whatever device you want, anytime you want, including prescriptions. They use an AI interface on the front end to help screen. It's great for young mothers in particular who just want to know, do I need to do anything about this situation with my child? And often those problems are solved. And then if they need to see a physician or a nurse, they can do that right away. We'll come to the challenges. But I think the most important thing about Amazon, or about the Netflix of healthcare, about Babylon Health, is that they only select 1 in 100 doctors. It's not your warm body. It's not the fact that you were, the last guy or gal that graduated in your medical school. You call them a doctor. They handpick. They screen people. And that's important because you've got people who actually want to work in this environment. If I tried to force some of you to do this, you wouldn't like it. You wouldn't choose to practice medicine in this kind of way. There are people that want to do that want to practice medicine this way. Why wouldn't you have people who want to practice medicine in that way? Instead of trying to get everybody to do it, you pick the people who want to do it. Mercy Virtual Hospital. All of these are real, all of these are current. I'm not inventing any of this, and none of this is futuristic. It's all present, right? This is not a futuristic talk. This is a present talk. Mercy Virtual Center in St. Louis, I've been there last year, and they have no patients. None. Although they treat over 400 patients every day. But those patients are at home or in ICU beds in community hospitals. So you're using resources in other centers, keeping people close to home. The doctors and the nurses work in that hospital with not one patient. We're still building hospitals. We're still building huge, multiple billion-dollar hospitals to bring people there when most people don't really want to be there for a lot of reasons. And as medical professionals, we know the risks of being there. People want to be elsewhere. The outcomes are better at Mercy. They've been in existence for almost 10 years now, so this is not new. Again, this is not a future talk, this is a present talk. They have better outcomes, significantly improved science satisfaction for individuals, and lower cost. The physicians and the nurses who work there work in little pods. I call them pods. I don't know what their technical term is. They have amazing resolution in their technology and an amazing partnership. They didn't invent all this. They have dozens of partners across the sector, which is another theme we'll come to, that are able to have resource and access to all the information that they need to deal with that individual, whether they're in an inpatient situation or remotely, and they can get instant consults with their colleagues. That's real time. We talk about transformation. We've talked about transformation since forever, since I've been in healthcare. We've talked about it. Transformation is really hard. In the physical world, to go through the metamorphosis stages of becoming a butterfly is a very difficult process. I'm not sure you and I would want to go through that process. We have had historically in our societies major disruptions. They've been called black swans, things people didn't think about, things people didn't plan for. And the one that I love the most is the Gutenberg Bible, because the Gutenberg Bible was printing the word of the Bible. And then from that, the translations into people's own languages, people could read the Bible. The changes over the next 400 years from that innovation and that technology change, no one imagined. Disruptions across society, disruptions across governments, still going on. Major, major societal change as a result of that. Which brings me to the point that Machiavelli reminds us that it is very difficult to change the status quo. In fact, he says it's the most difficult assignment. He warns about that because so few people are interested in where we're going or where we need to go, and so many are vested in the status quo, in the maintenance of the status quo. It's really hard to get the energy to break free from the gravity of the status quo. But it's happening all around us, and you know this as well as I do. There's that digital new sphere that's happening. It's happening in pockets. It's happening in industries. Google and Amazon and others are very interested in understanding the value of the data. And that is really the conversation that we'll be having today, because that is both the challenge and the opportunity, is what we do with that data. Another disruptor might be Uber Health, and they come to your door with healthcare. Like when I was a family doctor in Guelph, Ontario, I used to make host calls. So it resonates to me that we're going back to an Uber healthcare. That is with a cost. Again, remember the Netflix of healthcare was what, $9 a month? I don't know what the Uber healthcare is, but it's probably more than that. Everyone's talked to you and to many others about the cost of healthcare. It's the largest service industry in the world, service and goods industry in the world. And so changing that is really hard. Really, really hard. Yet we have compelling reasons to want to. We know that at least 30% of what we spend on healthcare has no value and may in fact hurt people. Most people don't think about the fact that medical error is the third leading cause of death in this country. You don't see that in the headline of the paper, but it is. So the status quo, doing the same thing, and thinking about doing the same thing all the time is not getting us where we want to go. Most provincial budgets in healthcare, 41 to 50% of the entire provincial budget. And is that changing? No. What's the pressure? To put more money in to do the same thing. In the US, it's now, I believe, 18% of GDP. When it was 16, people were pulling their hair out. It's going to be 20. Before this talk's finished, probably. It'll be funny. But there is an opportunity with connecting the digital glue to be able to reduce cost by improving efficiency. And these are some of the unnecessary face-to-face interviews. You know, I know people, and I know physicians, and across this country, and they're not bad people, require a woman to come every month to get her birth control pills renewed. Why is that? Because the economic model, it makes it beneficial for them to do that. But we could save a whole lot of money and a whole lot of time for those physicians and providers if we were to be able to integrate some of the things we'll talk about in a minute. There are many examples of what you can do, as you can see, to avoid of unnecessary visits. And those are just, you know, 50, the most outlier there is 50%. That's the biggest. And that's only, you know, those are significant dollars, but it gets much bigger the greater the adoption. So there are huge cost reasons and quality reasons, I think, and particularly around medication errors for driving to a digital space. And it saves time. You know, and I used to say, you know, when I was a primary care physician, save me time and you save me money. And we have that opportunity today to save people time. And not only physicians and nurses and healthcare providers, because that's not the point of this conversation, but it's about you. The cost to society of you taking time off to drive downtown to see a doctor or wherever, that's a loss of productivity cost at the end of the day. So there are lots and lots of examples of how we can improve that. What Canadians want are these things, very basic things. We have that data. Canadians want access to their health information. You know, it's not that complicated, really. But I said this is not about technology. This is about the social interaction, the social enterprise. People want to be able to email their healthcare provider. People want to be able to FaceTime their healthcare provider. They FaceTime their family in Hong Kong. Why can't they FaceTime their physician? That's how we structure things. That's how we think about how we structure things. People want to be able to get a prescription renewal. Why do I have to take time off work to go see the doctor to get a prescription renewal for my birth control pills, for example? Hello? This is 2018. But putting all those pieces together in this siloized environment is a huge social challenge. It's not a technical challenge. It's a social challenge. It's how we think about healthcare. And I think the heart of the healthcare environment that we see developing very quickly today is around that flow of data. You know, many people have devices, and these devices track our heart rates, and the heart rates are beamed up to the cloud, and millions of people are doing that. And folks discovered, not intentionally, they discovered that they could predict atrial fibrillation. It's a big issue for stroke, and many of you know a great deal about that. If we can prevent and intervene on some of those small items, that's a huge benefit to many, many, many people. They didn't set out to do that. It was an accident, you might say. But that's what happens when you bring together large amounts of data. And when we talk about big data, we mean volume, velocity, and variety of that data. Data is not, in the world that we're in today, descriptive analytics or the epidemiology that I grew up with. It's not at all that. It's real-time data. That means you're taking audio data, you're taking video data, you're taking all kinds of information and analyzing large amounts of traffic in a variety of areas, including genomic and other specific individual data pieces, and starting to look at patterns associated with that. And that's where it becomes interesting. That's where it becomes a policy issue. The digital railroad that connects us and all those pieces across the country is not a technological challenge, it's a social enterprise. I believe there's a role for the federal government in that space that is not seen by most people, that digital space that connects all of those elements together. There is a role for the federal government, particularly around legislation. We hear a lot about privacy and the Europeans and the GDPR, and those are important issues, and security. Those are all important issues. But that's not the most important issue. I think we need to think about the social consequences. Who validates the algorithms? Who oversees the algorithms who are making choices today? The algorithms making choices today. There's an excellent book that's just out by Virginia Eubanks called Automating Inequality. And she runs through a variety of very important examples, US examples granted, where currently today people are screened based on algorithms, and they may be screened as a risk for child abuse because they're poor and they couldn't afford a medication, and their children are being taken from them. People are being screened for access to homes who are homeless based on algorithms. So if you're homeless intermittent over a period of time, you don't get that. somebody else gets it. So the algorithms are making decisions, and the ability to increase inequality, I think, is something that we need to think about. There is a legislative component that I believe addresses what I would call quality, because there is no federal quality legislation, to tie these pieces together and why are we doing this? Who's going to oversee this? What public governance role is going to be put in place? Because the other folks we were talking about, not that they're bad people, the Amazons and the Googles and Apples, they're all reasonable people, I'm sure. But their motivation is different, as we have seen. There needs to be public oversight. That's not to say there is not an incredibly important role for the private sector in partnership, absolutely. But it's not about that. It's about data ownership, data governance, and making sure that somebody's thinking about the validation of the algorithms. That's a whole new area that nobody's talking about who's going to oversee that area. This is what I call Medicare 2.0. It's moving beyond the Canada Health Act principles. Not that there's anything wrong with those principles. But we need to see that the future is changing before our eyes. The present is changing to the future before our eyes. And if we fail to imagine both the risks and the benefits, then we may find ourselves in a society that has very much a widening inequality. And that may not be the Canadian value that we have. Those who can afford to pay for the Netflix of healthcare have instant access, get the Uber Health to their door, and other people who are screened out because of algorithms that decide they don't fit that criteria. No one's looking at that. That's a role, I think, for a federal government. I think that's a Canadian opportunity to reimagine Medicare. Imagine if we had air traffic control systems in each province and territory. Every time I came from Halifax, I'd have to land somewhere multiple times to be able to get to Toronto. Wouldn't function, right? It's that digital air traffic control for healthcare. There is a space not being filled. And it doesn't mean you're getting into the world of provinces and territories. They're obviously delivering health care on the front line. This is a new space. This is a digital railroad that we have to imagine. Everyone's heard about the privacy challenges of Facebook and Cambridge Analytica. It's just the beginning. We start to look at the multiple data sets in healthcare, and it becomes much more complicated. For me, this is about quality healthcare. It's always been about quality healthcare, and that's about efficiency, better outcome, better cost. That's something that we all, I think, in healthcare want to try and achieve. We have that opportunity with digital to make those connections, to actually see what works and what doesn't. Because we know that a lot of things don't work. We just don't know in this situation all the time. Sometimes we do, sometimes we don't. The ability to connect those dots is a real motivator for why we need to have that national oversight. This is what we talk about when we talk about a real-time ecosystem. This is the connection of the biological data, your social network data, your device, your connection with your healthcare provider. There's AI, machine learning in the background here. And yes, there's elements of interesting algorithms like distributive ledger in there as well. All cloud-based. But who's going to oversee that? Because it's happening all around us without the Canadian public oversight. So for me, it's really all about access to quality health care when and where you need it. But I think there is a role to think about a new space that hasn't been defined, that has certain risks and certain opportunities, that has major implications for society and how we see and appreciate individuals within our society. Canada has a more egalitarian value system than some other jurisdictions just south, across the line. And we pride ourselves in that, and that's a great thing. But we're at risk of failing to imagine the risks and the opportunities And many in the technology will say this is all the good things that are going to happen, and that's great. But there are also a whole lot of risks. Just like those people on that ward way back in 1972 who had psychosurgery, who thought that was going to improve their lives, and they're housebound or institution-bound, really, for the rest of their lives with the best intentions. Let's not make the same mistakes again. Let's have some questions and a conversation. Thank you.
Just as a reminder for question and answer, there's the mics along each side, and so if you wanted to go up to one of the mics and then Peter can address you.
Hello, I'm Kathy Kastner. My education is involved in research amongst other things. On the question of privacy, I've been at a couple of California conferences, Health 2.0, Patients 2.0, where patients have stood up and have said that health trumps privacy. And I wonder what your thoughts are about that.
Yeah, no, it's a great question. Does healthcare trump privacy? I think people are giving over privacy, all have been for some time, with their click on your device to be able to use it. People want to see that result right away. They're not reading that 25, 50-page legal agreement that goes with that click. That's clear. People want to be able to have the advantages of WhatsApp right now so they can talk to their friends or whatever. It's no different in healthcare. I think people are coming to an understanding that they want access to healthcare, the things we talked about. People want to be able to email. People want to be able to talk to their healthcare provider when and where they want it, which is right now, because that's the way people's lives are. Why is healthcare any different? The structural institutions, that are very much 19th, early 20th century based, let's be honest, structurally, haven't changed. People today are getting around that in the healthcare space. Let me give you an example: medical marijuana. You have to have an interview to get your medical marijuana. So people are doing it online. The doctors in Ontario and the patients in BC. Real example. The physician's not licensed in BC. That's against the law, but it's happening every single day. So people are more concerned about access than they are about those old 19th, 20th century institutions. So that's what I'm talking about. It's getting our heads around the institutional changes, the implications around that, and we can create a digital space in some ways that ties it all together.
Hi there. My name is Malik from Healthcare Event Planning, and I just wondered if you could maybe provide some more details about Uber Health. I don't know if it's in Canada yet. I can't see any articles about it. But if it's not, what are some of the barriers for adoption?
Well, I'm not an expert on Uber Health by any means, and I think, first of all, Uber isn't everywhere in Canada, let alone Uber Health. So it's more of a evolving. It certainly does exist. I think there's nothing wrong with Uber Health. These are healthcare professionals, I assume, licensed and regulated in the provinces and territories that they're in. Although, again, it's not really outside an urban environment. I'm not really aware of that occurring yet. More importantly, I think it's the sort of underground economic component to this that I think. Uber has disrupted, as you know, the taxi industry tremendously in many places, not everywhere, but hugely in places like New York City, hugely in large urban areas. And that's where the Uber Health comes in. You can see it happening just like the Babylon example. You can see it happening because it fulfills a need. You just want to get something now. You want to have your problem solved now. I'm going to pay $10, $20 to get that done. That's the point.
Hi there, Zanita Herji, Accenture Health. Really enjoyed the presentation, and You brought up some excellent points, especially towards the end with regards to the role of the federal government. At your level, when you have those discussions with federal counterparts, what's the readiness and the willingness of the federal government to introduce legislation so that we can begin to create data sharing agreements in a more timely fashion?
It's a great question. I think there's a lot of interest in the federal government around the creation of an oversight of this real-time health ecosystem. I don't think there is appetite for an understanding around the need for legislation. Legislation is a big, heavy tool that, you know, I'm a former deputy minister in Nova Scotia, and you have to have legislation to allow major structural change, to integrate some of those 19th, 20th century structures. The federal government is not really, I don't think, interested yet, because I don't think they really understand this conversation around the implications. I think if they did, they would understand Medicare 2.0 requires that kind of a legislative foundation, and to really institutionalize quality and moving beyond the sort of general vague principles of the Canada Health Act. So I don't think there is leadership in the federal government yet that really wants to champion this. That's why we're out trying to talk to people.
Hi, Peter. John Ronson from TELUS Health.
Hi, John.
I think a variation on the previous question. So you look back, there are actually very few examples of where the federal government has actually intervened or the Supreme Court has intervened to do what you're proposing. There are some. Telcos are actually an example because it was really when the telcos started doing things internationally and you know, telephone switching occurred long distance across borders and things that eventually they intervened and did something about it. But I think I have the same fear that you do. Like, this is coming more quickly, I believe, than we think it is, and a lot of it's happening through the so-called FANG companies south of the border. Yeah. And so how do we kind of raise the temperature, or it'll be the classic boiled frog if we don't get at this fairly quickly? It would be my sense.
Yeah, no, I think it's a great question, John. I think what we're doing here today is having this conversation, right? I think that it's that failure of imagination. It's not on our radar screen. One of the challenges of our wonderful access of our tools is it limits our resources, right? We're getting fewer and fewer points of opinion, and everything is sort of confirmatory. So, you know, we need more conversations like this, where it's outside of that sort of bot that's screening things that we like to see all the time, to have conversations about things we haven't thought about that are probably more important than some of the other conversations most of the time. I think that what I'm trying to do is what you're trying to do is, you know, write about it, talk about it, engage other people to think about it, and to start to raise up the awareness that we need to do something right now. And I think that's what democracy is about, and that's what we're trying to do. That's what I'm trying to do, and I know that's what you're trying to do.
Vaughan, thanks for the talk. Patrick Hupp here from Medtronic Canada. Just a quick question for you. You were talking about outcomes and cost. Yeah. So that remember me of the principles of value-based healthcare put forward mainly through Harvard University with Professor Kaplan and Porter. Knowing that and knowing the fact that the provinces are a key player in the adoption of that and the promotion of it despite your federal mandate, I was wondering who across Canada so far you would see as a pioneer or at the forefront of embracing those kind of things in terms of provinces, knowing that you have also a provincial experience.
Yeah, well, you know, I'd be remiss not to note that when I was deputy in Nova Scotia, that we consolidated structure significantly. We realigned the ministry to focus on risk and data analytics, and we introduced the personal health record for every citizen in the province. I don't think anyone else has done any of that, that big, heavy lifting part. And we kept the cost at zero. So, you know, I think there are very few examples where provinces are making the big structural changes, and some of this is big structural heavy lifting, and you do need legislation. Governments generally don't want to do that because it's hard work. And so it's easier to dole out a check here and there, to fund some initiatives here and there, and to win some short-term success in their election cycles. Now, I'm not blaming them, but that is what is going on. And there are many good examples of good things happening across the country, but it tends to be within that, here's a check, and here's some money, and it's very defined and very narrow. What I'm talking about is the big picture here. Another question?
Thanks very much for the talk. I'm the CEO of a small startup, and while we all believe in the vision, I happen to believe that the private sector has a significant opportunity in actually creating value and developing some of the future.
Yeah.
Challenge that we face along with a number of startups is understanding the path to adoption and understanding the path to commercialization in healthcare.
Yeah.
Easier to succeed south of the border.
Yeah.
As much as we look at it
Yeah.
and we say we're not going to do that.
Yeah.
I can tell you, you know, the first 3 quarters of our user base
Yeah.
all came from the U.S.
Yeah.
We're a small company based in Calgary.
Yeah.
What advice do you have for startups?
Well, you know, many CEOs like yourself used to come talk to me about those challenges, and some really, really great companies. And there's one that I love, which was a Halifax-based company called Kinduct. And, you know, Kinduct is like, you know, people know about Moneyball. Well, it's sort of, he started out in healthcare and couldn't get anybody to get interested in his integration of data to be able to assist with management. But so he pivoted, like good entrepreneurs do, to the sports sector, and has done remarkably well by using that sort of approach and integration of all the data points in the professional sports teams to actually demonstrate value. It's exactly the same model as in healthcare, but the healthcare environment is so 19th century regulatory that it is so very, very challenging to break into that. And as I said, Ann Snowden's 3 years to get 2 data agreements, you know, right here in Toronto, you know, where people are supposed to be thinking about that kind of thing. So, you know, I think what I'm trying to create and talk to you about is creating that digital space that has data oversight and governance, where you and many other private sector folks can be playing in that space with all the requirements around confidentiality and security and frankly, you know, algorithm oversight and regulation, I think, is coming. It needs to come, but a public governance. So we make sure we don't run into the Facebook Cambridge Analytics kind of approach. So I think it's certainly doable, and that's what we want to do. That's what I know at InfoWay we are trying to do, and with partners and many other folks that are trying to create that. But it's about partnerships with public-private, but public oversight.
My name is Bali with Clorox Healthcare Infection Prevention. You spoke about elections, and I just jumped back to watching the news over the last couple of days, and so many announcements in Ontario, particularly around new hospitals being built to try and deal with the hallway healthcare that's going on right now. But at the same time, it's pulling at me about the ability to potentially have solutions that are information related like this, where you can actually have like facility and infrastructure to be able to take advantage of that. But then there's continuous infusion of billions of dollars in the healthcare. So how do you balance between the politicians' immediate need to address the hallway healthcare need right now with potential big solutions that could be paradigm changing like this?
Yeah, well, you know, I think just to blow InfoWay's horn a little bit on that, I think InfoWay is doing that with electronic prescribing, e-prescribe it, with a partnership, you know, with private sector and provinces and territories, and a hell of a lot of people in the pharmacy sector working hard to achieve that. So I think it is possible to do. within reasonable cost, all of those areas. So I think it is possible to do, but it does take leadership, it does take governance and oversight, and I think that's what I'm really trying to get at. Thank you. I think this is a final question, is that right? Yeah.
The validation of algorithms, who can do that? What sort of credentials would a person need? Do these types of people exist? You know, being maybe a data scientist and a sociologist at the same time? I don't see many of these people.
That's a great question. You know, the fact that you're asking about it is really my goal today, to get people to start to think about that, because we're not. We're not. I think it is a multidisciplinary oversight, a regulatory kind of oversight, like we have in other jurisdictions. You know, could something like a CADIF do that with additional kinds of resource? Probably. I don't think we need to invent new entities, but I think we need to train people differently. I don't think the universities, and this isn't a whole other rant, I don't think universities and colleges are necessarily training people for today, let alone tomorrow. They're often limited by their teachers' thinking, and their teachers thinking about what they learned 30, 40 years ago, and that's not what we need today. So I think this is a discussion we need to carry on, but I think we need different skill sets. We need all of those components coming together with a new kind of curriculum. And I know there are places doing that, at least 15 different programs across the U.S. I've been talking to people in Canada, and they're starting to make some adjustments in terms of their curriculum. But it's really giving students a leg up in jobs that are going to be highly valued in data analytics, but not the data analytics that people traditionally think about, but it's the oversight and the regulatory component. Thinking about the implications of who's selecting what person may have dire consequences for individuals. And we're not even thinking about that. Most people aren't. So thank you for your question.
Before you get going, our next breakfast with the Chiefs is, I believe, June 6th. Watch out for the invitations. It will be with Dr. Ed Brown from OTN, and he will be here. So have a good morning.